Hello and welcome to Conversations with Dr. Bachner. I'm delighted once again to be joined by Robert Redfield, Bob, who's director of the CDC. Welcome, Bob.
Thank you very much. Glad to be here, Howard.
So, Bob, so much data crosses your desk. What new data have you seen over the last couple weeks that have been interesting that you think clinicians and the public would want to know about?
Well, I think, Howard, probably the most important thing is we are beginning, I think, to turn the tide on what I call the southern outbreak in the nation. I think I've seen pretty strong data that the mitigation steps that we've advocated, something as simple as a face mask, social distancing, washing your hands, closing bars, and having limited indoor dining at restaurants. If you see how Arizona, for example, put that in play, and literally you saw, about 2 to 4 weeks later, you really see that we can get control of this pandemic. We don't have to close retail. We don't have to lock down. We really just need to wear face coverings when we can't social distance, wash our hands, and be smart about crowds, particularly, obviously, the overcrowding that occurs in bars and indoor restaurants. And we can get this outbreak under control. And we're now starting to see that take effect, I think, more broadly across the South. And I think it's really important. We're going to talk more about, my big concern about the flu and COVID coming together. Clearly, we'd like to see these mitigation steps really slow the impact of COVID now, so we can get those in full practice and full operation as we move into the fall, while you and I talk more about the importance of what we can do to prepare for flu with flu immunization.
Yeah, when we talked the last time, we were up around 60,000 cases. The deaths are still high, over 1,000 a day, but now we're down to about 40,000, maybe 50,000 cases. I think your comment about Arizona is interesting. People can't expect that we put these mitigation strategies in place and tomorrow the cases go away. And that's preventive medicine and preventive health. It prevents it in the future, and I think that's been difficult. Where do you want us to be? Where do you want us to be in September, October? 10,000 cases across the U.S., 20,000 cases. What is there a number that you have a sense where if we're at that number, it would create a greater sense of safety as we move into the fall?
Yeah, clearly I'd like to see us get down under where we were in June. I'd like to see us down under 10,000 cases, and obviously see fewer and fewer jurisdictions that we would consider in the red zone. Like to see the prevalence of positive testing around 3% across the country. It's hard to believe. I was looking at New York data today.
Yeah, it's amazing.
1%.
Yeah.
1.3% for the state. We were at 42%.
Yeah, it's amazing.
And I don't think New Yorkers are any more adherent to the mitigation strategies that we are. It just shows that a combination of events, obviously being impacted by the outbreak and probably some increased immunity that occurred as a consequence of the infections, coupled with many people probably have been impacted and understand this is serious. So the mitigation steps, to see New York now under 1%, under 2%, 1%, 1.3%, just sheds the rest of the nation. When you ask me where do we want to be, that's where I want to be. I want us all under 3%. I want to see mortality rate under 250 people, and then I want to see it lower than that.
Yeah.
I think you're going to see, as you commented, when we looked at Arizona, when the governor put in these mitigation steps, for the next 2 weeks, everything kept going up, up. And then for the next 2 weeks, it started to go down. But so 4 weeks after he started, he was where he started. And some people could say, see, nothing works. But they stayed with it. And now you've seen the progressive drop. And Arizona is really moving in the right direction. So it is important to understand these interventions are going to have a lag. That lag is going to be 3-4 weeks. You and I are going to see the cases continue to drop. And then hopefully this week and next week, you're going to start seeing the death rate really start to drop again. You know, we got down under 500. We actually got as low as 250 one day. I think we're going to start to see a decline in mortality across the country now next week as we continue to get control of these cases. And I will say there's a warning sign that we all have tried to put out there. Ambassador Birx just got back. I think she visited 21 states, that we're starting to see some of the cases now in the red zone areas are falling. But if you look at those states that are in what's called the yellow zone, between 5 and 10%, they're not falling. So middle America right now is getting stuck, you know, and this is why it's so important for middle America to recognize the mitigation steps that we talked about mass social distancing, hand washing, closing bars, being smart about crowds. It's for middle America too, the Nebraskas, the Oklahomas. We need to see those embraced. We don't need to have a third wave in the heartlands right now. We need to prevent that, particularly as we're coming on the fall.
Bob, you had mentioned herd immunity, and different things have crossed my desk more recently. You know, CDC had a paper in JAMA Internal Medicine about 10% of the U.S. population. That was the best estimate. There's 330 million people who live in the U.S. You know, if we have an infectious rate of 10 to 20%, that's about 60 million people may have been infected. I think, do you have a sense of what that percent is around the country? We see isolated reports, but we don't see really good national data on the percent of the population that's been infected. Do you have any sense of what that may be?
We're in the process of obviously following up with the report that we did in JAMA that kind of let us understand that, you know, maybe for the 2 million cases we diagnosed, we had an estimated 20 million people infected. We've now expanded that throughout the country. So very large surveillance, work in progress. So I don't want to speculate and really want to be data driven, but there is enormous geographic variation. Yeah. I can tell you that we have some areas that we're looking at less than 1%, and we have other areas that we're looking at 20%. So we are going to be calculating that. I think if you're going to do a crude estimate, somewhere between 30 and 60 million people, but let's let the data come out and see what it shows.
There's been some question about what we would need for herd immunity. Now, we know vaccines are coming. Some people have said as high as 60, 70%. Other people have said as low as 40 or 50%. You care to comment on the varying figures, or it's all speculation?
Yeah, I've learned this. You know, CDC's not an opinion organization, really science-based, data-driven. It's great to stay in that discipline. But I will say this is how much herd immunity we need to get the R naught under 1 really also depends partially on how effective the mitigation strategies are that we're using. And we may find that, you know, even if we're at a 30 to 50% history of immunity, that combined with the mitigation steps that I just told you may really take us under the R naught of 1 and really have impact. So I'm not one that's going to say, hey, listen, if it's not 70% or 85%, it's not going to help us. I kind of agree. I'm a believer now in this, what I call partial herd immunity. You know, the impact of pre-existing immunity on the ability of this virus to maintain an R naught greater than 1. And again, the importance of the mitigation steps. But I do think there's growing evidence. You know, this week a number of papers came out again to provide more data about the importance of T-cell immunity and innate immunity. And as I mentioned, unfortunately, there's great variation. You know, but there is a reasonable speculation that the reason the Northeast is doing so well right now is not 100% because they're more adherent to the mitigation steps. There may be, in fact, an impact of immunity that, combined with mitigation, gets through a threshold that keeps this virus. So I think we're going to learn a lot more about it. I think you know, I think it's going to contribute more than some people realize in certain areas to our ability to have better slowing of the spread as we go through the fall.
Yeah, I know there are certainly certain areas of New York City boroughs where it was clear that well above 20, 25% of the population had been infected. And I think the story about neutralizing antibodies and then T and B cell responses are still uncertain, so we'll see how it plays out. Now, as happens, I had forgotten that your paper was coming out today. It's entitled "Addressing Influenza Vaccination Disparities During the COVID-19 Pandemic." Three CDC officers, Lisa Grosskopf, Leandris Liebert, and you're the senior author. Probably the critical issue for the fall. We hover somewhere around 40-50% influenza vaccination, and I know people would really like to see it at 70 or 80 or 90%. You want to talk a little bit about that for the fall?
Yeah, Howard, I appreciate it. I appreciate the journal publishing this, and I appreciate the time to talk about it, because this is so important. I think people have heard me talk before about the importance of vaccination in general being one of the most important, if I use the term, gifts or contributions of science to modern medicine. I think this fall, nothing can be more important than to try to increase the American public's decision to embrace flu vaccine with confidence. We've gone through the hesitancy. I want to move people to vaccinate with confidence. As you commented, less than 50% of the American public get vaccinated. And when we look at that, we obviously see even significant disparities among Native Americans, African Americans, Hispanic populations. This is just going to add to the health disparities that we see. Leandris Liebert is one of my chief equity officer for our response, and one of the reasons we did this together. And we're working on building campaigns to increase the acceptance of vaccination, particularly vaccination with confidence. You've heard me say that this fall and winter could be one of the most complicated public health times we have, with the two coming at the same time. On the other hand, I'm an optimist that if the American public heeds the advice that we said about the face covering and the social distancing, the hand washing, and being smart about crowds, this could be one of the best flu seasons we had, and particularly if they do one more thing, and that is to embrace the flu vaccine with confidence. And that's really what we're trying to do. Normally, CDC has a very good program for uninsured children to be able to provide vaccinations, including flu. But we have a limited program for uninsured adults. Only about 500,000 doses do we provide to the states, local, tribal, territory health departments to help them with the uninsured adults. This year, I purchased an additional 9.3 million doses because I believe that it's important that all individuals get access to the flu vaccine this year. So I do appreciate the opportunity, because the key to that, a lot of it is going to be obviously healthcare providers to remind people to do it. I was glad to see the Secretary of Health yesterday added pharmacists to not only be able to vaccinate adults, but now pharmacists can vaccinate children 3 to 18 in addition to adults, so we can expand the accessibility of vaccines. So I think it's really important. I'm happy to ask specific questions, but we've got, and my goal this year is to get us up to 65% vaccine acceptance across the board. Now in children, we usually get in the 60s, yeah. But in adults, we're frequently in the high 30s. I think this is a critical year for us to try to take flu as much off the table as we can as a respiratory pathogen that's going to cause people to be sick enough to have to go into the hospital. The biggest fear I have, of course, by the COVID and flu at the same time, is that our hospital capacity could get strained. And when you really look at the impact that we saw in New York, where we had very high mortality rates, if you go back and look at New York,
yeah, very.
It wasn't that the practice of medicine was not as good in New York. It was probably better than many parts in the country. But when the health system gets overwhelmed, we find that with COVID, this is where the mortality seemed to be the greatest. So my goal is to ask the American public to do their part, ask our, obviously the American Medical Association, doctors, healthcare providers to do their part. Let's get the American public vaccinated against flu. And the flu vaccine is now available. And hopefully, the viewpoint that we put out will just help remind people that this is the time. Don't leave this enormous advancement in medicine on the shelf for yourself, for your community, for your family, and for your patients. To really push forward about the importance of flu vaccination.
Bob, I spoke to Zeke Emanuel yesterday, and we were talking about both flu and then the other vaccines. And one of the issues that came up is a delivery system. It's hard for people to get to see their physician now in many places, and that's often where they did get their vaccination. And people aren't coming to work. Work was another place, so a lot of people are working from home. So the 9.5 million doses that you purchased, or flu vaccination in general, have you thought through delivery systems? Because that same delivery system ultimately could be used for vaccine for COVID-19. So I'm wondering if you've begun to spend some time thinking through a delivery system for 330 million Americans.
Yeah, very important. Clearly, we can talk about COVID in a minute, but clearly taking advantage of expanding our capacity to deliver flu vaccine. So I mentioned already, I know there was skepticism a number of years ago when the decision was to allow pharmacists to give vaccines. But I think what an important decision that was for access to vaccination, particularly flu vaccine. I'm very excited that just this week, the Secretary of Health and Human Services put through that not only can pharmacists do adults now, they can do children 3 to 18. So if you have a pharmacy, you can be able to get your flu vaccine in the context of the pharmacy. I will say, my wife used to let me give her a flu vaccine, but ever since pharmacists could do it, she always goes to the pharmacy to get her flu vaccine. It's convenient. We also are looking, in our campaign right now that we're doing with flu to try to increase our ability to close some of the discrepancies that we're seeing, particularly with Native Americans, African Americans, and Hispanics. We're looking at other strategies in terms of expanding our flu campaign. Initially we were looking to expand a lot of vaccinations back the way we did it in the older days, back in schools, as you mentioned. Well, not all the schools are open.
Right.
So we're continuing to look at the same thing about providing mobile units that may be in particular rural areas to be able to get expanded vaccination. In terms of COVID, CDC sort of has the ball in terms of developing a distribution system for when a safe and efficacious COVID virus vaccine is approved, which I cautiously optimistic will happen this fall. Then how do we operationalize that?
Right.
In a priority way, but eventually for the whole nation. It's not as same as we do for flu, where there's already relationships between pharmaceutical companies and distributions and physician offices. So we are in the process of setting up, in partnership with the state, local, tribal, territory health departments, a distribution system when that vaccine becomes available. Recently, the same group that helps us with our immunization program was just awarded about, I think, a little over $300 million to start working with us. We've done what we call micro distribution plans in 5 states that we started last week to work through all the mechanics. And as soon as we do that, then we'll be expanding across the nation, because it's not going to help us to have a COVID vaccine that we can't get distributed into the arms of individuals. But I do think, don't underestimate the additional gift we have as doctors and nurses and nurse practitioners and PAs that we now have by our pharmacist colleagues being able to also distribute vaccines, particularly now that their ability has been expanded to include children.
Yeah, no, and I go and pick up my med once a month. It's the perfect time for me to get the flu vaccine, and pharmacies have remained open. So, and I think there's quite a few of them. It's been a rough couple weeks for schools and colleges. I think colleges began to open, and then it didn't work very well. Schools have been very highly variable around the country. Most of the major school districts, I live in Chicago, are not opening for in-person education. People are particularly concerned about younger children. How do you see that playing out for schools and colleges, Bob?
My position that if to really understand the importance, the public health importance of getting these schools open, K through 12s for sure. Obviously for our nation, it's important that our institutes of higher learning get opened. We don't need to do a educational pause as a nation for a couple of years. But it's got to be done safely, it's got to be done sensibly. It's got to be done with an understanding that COVID cases are going to occur in K through 12s, and they're going to occur in universities. And we try to enter dialogue with technical assistance with both to help people understand what is the reaction and the response. Because if the response is the first time they have a case is they're going to close the schools, well then we're not going to get to where we need to get. The other thing I will say, and it's interesting, I was just looking, I just was in a meeting where we looked at the number of states. If you look at the combination of hybrid and in-state learning, about 80% of the schools are either offering hybrid or face-to-face learning. There's only a smaller percent that are only offering the distance learning. That said, it's got to be done safely and sensibly. It's got to gain the confidence of the teachers, the students, and the parents. I try to tell people the most important thing we can do to help get our schools open and keep them open is control the community transmission in the community, because I do try to get people to realize as we're diagnosing these cases in schools, now the K through 12 in particular, those cases are not being acquired in the school. They're being acquired in the community, and we're obviously working to evaluate those with a number of schools so we can reinforce the importance of controlling. Universities, I think they really do have to have a strategy or surveillance strategy, a testing surveillance strategy. Obviously, just testing students when they come on campus, that's not a strategy that's going to get you to the end of the game. We're there to keep working with the schools, the higher learning schools, to help them develop that strategy. But I do think there's an area that can still benefit from dialogue to how to develop that strategy. How do you open a university? How do you use the mitigation strategies we talked? How do you use surveillance testing to help you keep that school open? How do you respond to the clusters? So it is a challenge, but I do think, and my biggest focus is the K through 12s, because I do believe that it's not only central to the child's academic success. These schools provide really important mental, nutritional, emotional support for children and their families. It's really in our nation's best interest to get this face-to-face learning back, and we got to do it safe and sensible. It's going to have to be flexible based on communities. And I just reiterate the commitment. CDC is available to provide technical assistance to any school district that wants to try to work through this. But it has been a rough week because I think there's a tendency when there's cases in the school for people to react as if it's the school that's the source of the transmission, not the community.
Right. Well, I think it relates to your first point. If the 40,000 cases a day was 5 or 10,000, then there's going to be less cases in schools and colleges.
That's right.
It all relates to each other. Preeti Malani is our ID associate editor, chief health officer at University of Michigan, and she's repeatedly reminded me testing isn't the strategy. It's what happens after you have a test positive. And so she's trying that's what she's got to figure out. Not that she's testing everyone who comes back to Ann Arbor, but what do you do when you have a positive case and how much ring testing you have to do.
Right.
Your staff is very clear. I have 5 minutes.
Wow. Are they controlling my time?
They are.
Howard, does that ever stop? I mean, I thought I was the director. I don't understand. I don't understand why the director is always the individual who's directed. I mean, there is definitely something wrong with that formula, isn't there?
It's 170,000 deaths. This is it's a difficult number. Any sense where that will end, Bob?
Howard, first I got to say it's, every loss of life is, you and I were physicians,
Oh,
it's tragic, you as a pediatrician, I know I lost my first son shortly after birth, and I responded by doing pediatrics out of Tripler. Taking care of sick children was even harder. Every loss of life is tragic. I do believe that, although I don't think critics will necessarily give us the benefit of the doubt, but when we had the first CDC models that were presented to me in late February, early March, they said that we were going to lose somewhere on the low end of 1 million and on the high end about 2.4 million before October. And I looked at that data and I kind of said, it was very difficult, I knew the power of a respiratory pandemic. Clearly this virus appeared at the time to have higher mortality than, say, influenza. And I think when it's, we'll see where that comes out once we see. Clearly in individuals with comorbidities, it has higher mortality. You've seen our estimates that we're close, coming up to, up to about 200,000 this year, but I don't really like to do estimates or models because I don't know what they mean and they're based on assumptions. But the fact that we're coming up on 170,000 people is a lot of people. I do think we're going to start to see significant declines in mortality across the country in the next, hopefully next week, we'll start to see a decline. It's going to lag cases by around 3 to 4 weeks. But this is a big loss of life. And this is why, if there's a message from us from a public health point of view, the most important thing we can do is do everything we can do to protect the vulnerable around us. Not just those in nursing homes, but also those of us that are elderly, that might have certain comorbidities, diabetes, hypertension, obesity, kidney disease, lung disease. We all have an important role to play. I always say, well, the reason I wear my mask is not to protect me. I wear my mask in case I'm infected to protect you, because I want COVID to stop with me. And if we could control the community spread, so when you're that young 30-year-old and you don't think there's a big deal if you get COVID, the problem is if you're jogging through Central Park and there's two 85-year-olds sitting on the bench and you have to, sneeze when you go by them, it's an important thing that all of us try to control the pandemic to protect the vulnerable. But I'm saddened that we've lost as many lives as we've lost. On the other hand, I feel that the response that we've done collectively as a nation has really saved a lot of lives. And that we need to stay vigilant to the mitigation steps right now, because come the fall, if we have flu causing its problems and we have COVID causing its problems, and they build on each other, we could end up with another loss of significant life. I'm hopeful that the steps we take to prevent COVID are going to prevent flu and other respiratory viruses. People are going to realize this is the year to get flu vaccine, and we'll begin to see our nation get through this pandemic as we then, and I do anticipate it will happen, begin to deploy an efficacious and safe COVID vaccine. And hopefully when you and I talk next spring, we'll have this pandemic behind us in this country.
Last question, and then I will let you go. Nationally, we're incredibly dependent on data from the CDC. It's the greatest resource that we have for national data. So, for example, there's some delay, but you produce the number of deaths per month in the United States. Will those data continue to flow from the CDC? They're critical for people to have access to.
Absolutely. I mean, it's the blood of CDC.
Yeah.
But if it's even more than that, Howard, one of the first things that I recognized when I became CDC director was that for a variety of reasons, our nation has failed to invest appropriately over the last 20, 30, 40, 50 years in what I call the core capabilities of public health. I had a presentation that was made to me, very priority obviously was opioid-related deaths. I almost lost one of my 6 children from contaminated cocaine with fentanyl. It's a priority for the president, priority for the secretary, and I got briefed on it. And when the briefing was finished, I asked what the data was through, and they told me March 2015, and I said, but it's April 2018.
Yeah.
And I was told that I didn't understand all the complexities of getting all the data. And then I remembered, like you, reading the MMWR, and frequently the MMWR was telling me what happened a year ago or 2. Getting data so it's real time and actionable has been a big thing. I can tell you now we get data within 48 hours on opioid deaths across this country. And we're on a big push. Congress has started to realize the need to do what we call data modernization. Originally gave me $50 million, recently another $500 million to begin to modernize, not just CDC's data, but we need to modernize the public health data system for the whole country, states, local health departments, territory, tribes. So we are deeply committed. We are expanding and modernizing, so our data should not just be real time. I want data to get to the point that it's predictive data analysis. And so we're actually predicting, using data to predict, and I'm confident you're going to see the data modernization that's currently being driven into CDC. It's going to obviously happen past my watch. But that's going to have tentacles into the public health data system across this nation. So it's definitely the lifeblood of CDC is data, and that lifeblood is meant to be available to the American public to have that data. And I can guarantee you that will continue, and it's going to, I think, be an exciting time as there's greater investment in the core capabilities of public health, particularly data modernization. When you think of where we are right now with the ability like we did with opioid overdoses and drug overdose deaths, what we did was we brought syndromic surveillance into it so that all of a sudden every medical record was a public health tool. All of a sudden we had thousands and thousands of new public health workers, nurses, doctors, PAs, nurse practitioners, social workers. Anything that was in that medical record now could be a public health tool if we just take that electronic medical record and be able to use that. So bringing electronic medical records, direct reporting from laboratories, putting all that into an integrated public health data system, I think is going to revolutionize the ability of data to be actionable. When we had the Avali syndrome, the ability to use that syndromic data system to go back and look and say, wait a minute, where are we seeing this severe pulmonary illness? And all of a sudden, we didn't have to wait, 30 days, 60 days, 90 days, 120 days, 6 months for reports. We could go right into the electronic medical records and pull out. So critical. I think it's just going to get stronger and stronger. And it is one of the critical roles that CDC does play as a group that can really pull that data and do the analytics that need to be, so there is a public health response to that data that can improve the human condition in this nation.
Yeah, well, I think one of the one of the things that underpinned the success in Taiwan, Korea, Singapore was this remarkable electronic health infrastructure. In part, they have other things that are more problematic than problematic for the U.S., but they have an underpinning of a data that we still are struggling with. Many questions, but 5 minutes over. Your staff will never let you come on my show again. So I have to say thank you, Bob. You and Steve Hahn at FDA, it's been a tough 6 months. I mean, you and Tony and Steve have really been in the limelight on a regular basis, so I just wish you good health.
Well, thanks a lot, and Howard, thanks for your continued opportunities to share our public health messages. We really appreciate JAMA, and the opportunity to get these viewpoints out some of our publications and you taking the extra time to let us communicate with you and your listeners on these important matters. Thank you very much.
Howard Bachner, Conversations with Dr. Bachner here at JAMA. Thanks, Bob. Stay healthy.
Yeah, thanks. God bless. Bye-bye.
Bye-bye.